Good afternoon. My name is Dr. Stephen Key from the University of California, Los Angeles, and this afternoon we're going to have a presentation on inferior vena cava filter retrieval, best practices from standard to complex. I'm joined on the podium this afternoon by Dr. Salazar from Mass General, Dr. Roshan from the University of Colorado, and Dr. Ahmed from the University of Chicago. And here are our disclosures. The learning objectives of this session are to identify patients at long-term risk of recurrent pulmonary embolism and accurately decide to retrieve an inferior vena cava filter or leave it implanted. To understand the risks associated with inferior vena cava filter retrieval, and to understand the similarities and differences between commercially approved inferior vena cava filters and when to utilize each. We'll begin today with a talk from Dr. Salazar.
Thank you very much. And as we are highlighting the issue of IVC filter retrieval, I just wanted to emphasize the importance of patient awareness and physician collaboration so that we can improve our practice. I'm going to address some of the issues. Why are we having issues retrieving IVC filter that contributes to a difficult retrieval? So just to highlight the dramatic increase of the rate of IVC filter insertions in the last 2 decades, mostly also not only in the total numbers of devices, but also for prophylactic indications. You can see that in the last 2 decades, we had a lot of filters placed in this country. Another side of the story then, how many of those filters actually get retrieved? And this is a large cohort published recently showing the IVC retrieval rates comparing 2010 and 2014. Now we're doing a little bit better, and that's a great thing, and I think largely because of the restrictions in some of the societal guidelines and also the FDA warnings towards the physicians community. So in 2010, we had 1 out of 7 filters being retrieved, and in 2014, we have 1 out of 4. Still, the rates are low, and what we found from this large cohort is that older patients are less likely to have retrieval, and depending on the location of the patient also, it's an implication, it's a factor for retrieval. Now, this is the reason why we have some scare or some scrutiny over IVC filter insertions. Now, we don't practice medicine for the lawyers, we practice medicine for the patients, so we do need to understand where we stand with the issue of IVC filter, even with the lack of high quality data. So this is the document from the SIR guidelines that was done in 2011, and I think it was very helpful because we started looking at trackable events, including the issues that we see nowadays with IVC filter penetration, filter movement, fracture, and then also the issue of recurrent PE in the setting of IVC filter. So it's very good for us to know this, and this is the extent of the problem. These are all filters at our institution that are causing problems. Not all of them are retrievable, but you can see fracture of the leg, filter migration to the heart, perforation, and thrombosis. This is a more recent report just showing and highlighting a case of appendicitis with a penetrating limb of a filter. And this is our own case at MGH, penetrating the duodenum and with the corresponding image of the endoscopy. Now, in 2014, we looked at reportable events, and again, this is data that it's coming from the MOD, and also it's voluntary reporting. But we do have an idea of the extent of the problem in terms of the retrievable filters. Of course, this paper shows more retrievable filters complications being reported as compared to permanent filters, and I think that's an issue of the number of filters that we've been placing in the last decade. And here, just an example of all these possible complications such as fracture, migration, limb embolization and tilting, penetration, IVC thrombus, and VTE-PE. So the other issue is the indications for filters, and we do not have good quality data. The only 2 randomized trials that look at the long-term outcomes of IVC filters, one done last 2 decades, PREPIC 1, that looked into the outcomes of pulmonary embolism, DVT, and mortality. While the permanent filters had some benefit in the PE prevention, there was a high incidence of DVT and no difference in mortality. Fast forward in 2015, when the same group of investigators looked at the retrievable filters and looked at outcomes at 3 and 6 months, there's no difference in IVC filter in terms of protection. And again, this is not really what we see in clinical practice because these patients are all on anticoagulation in both trials. That said, it's good to note that in this study protocol, the 3-month follow-up visit was done and a 90% retrieval rate. And again, just highlighting a little bit of the importance of having a follow-up clinic. Of course, this wasn't a protocol study, but I think we can learn a little bit from it. Now, we don't live in fairy tale randomized trials. The clinical practice looks more like this paper that is looking at the benefit of having an IVC filter in patients with multiple comorbidities, particular pulmonary embolism and cardiac issues. And in this graph, you can see the benefit of having an IVC filter present in that patient population. And I think this is more what we see, at least in our clinical practice. We see this complex number of patients, and moreover also the prophylactic indications for filters. So why are we having this problem? I think there's 3 major issues. The indications, there's some variation in the guidelines. We all know this, particularly when it comes to prophylactic indications. The other issue is that some of the temporary filters do stay permanently, and what are the patient-related factors that contribute to that, and who should decide when the filter should come out or not? So I think we're not really like 100% on top of it. And the last, but not the least, is we all know that prolonged dwell times can lead to difficult retrieval and lead from complications to the inferior vena cava. So let's look a little bit of the indications briefly. We do know we have a discrepancy, or not discrepancy, but a difference in guidelines from the SIR and American College of Chest Physicians, particularly when it comes to prophylactic filters. We do know retrievable filters are effective in preventing PES permanent. But we also know that from the literature that there is poor compliance with guidelines depending on who's ordering the filter. So it's very important that we get involved in this early on. And this is just to show the difference in one of the most used guidelines, in my opinion, the ACCP, where there is an absolute indication for IVC filter when there's contraindication for anticoagulation. The same thing with the absolute indications for SIR. But when you look at the SIR indications, there are prophylactic indications to the filter, and this is largely in perioperative setting or trauma patients. So what are the predictors of non-retrieval? So we do have some data on that. We already talked about age, malignancy, acute bleeding, PE, DVT, post-filter anticoagulation. They're all related to having a chance of a filter becoming permanent. Now, in terms of technical factors, I think this is a plus or minus for me, because if you have a center of excellence that is performing complex and retrieval techniques, perhaps that's not much of the problem. And we're going to talk about this in the next couple of presentations. This is very briefly to show the difference, and this is our own data from the IVC clinic, showing that prophylactic filters are significantly more, statistically more removed than other indications, such as absolute and relative. And again, age and cancer presenting as factors for non-retrieval. But when we look at the reasons for conversion, there's all sorts of things, but we just wanted to show here that short life expectancy plays a role in the decision, anticoagulation contraindication, a continued anticoagulation contraindication, and then immobility and chronic thrombosis. Sometimes we decide to leave it in. Complications, our data shows 8% complications, all sorts of things, but including thrombosis and lateral tilt. And this is, again, predictors of non-retrieval, pretty much consistent with the rest of the literature, malignancy, age, and VT, and the chart showing the filters that became permanent and the filters that could be retrieved and were retrieved in our follow-up. So what are the solutions for retrieval practices? Well, we all know that we have to reliably track our patients in follow-up so that we understand whether those filters should become permanent, or if we should remove it as soon as possible so that we don't have a prolonged dwell time, which we already know is associated with complications. In order to do so, I think quality improvement methods are very helpful in this setting. We can apply them. We can actually, if you're in a teaching institution, have your fellows involved. These are sort of ACGME requirements for training. And also, what we do a lot at our practice is focusing on patient and physician engagement. This is one of the examples. We put this 8 years ago, a notation in the chart so that everybody sees the patient has an IVC filter. So every time a patient goes into consultation, we ask the clinicians to reach out to us so that we can set up a clinic appointment. And we have seen significant improvement on the filters retrieved per month, and also on the time, on the dwell times, which I think is the key here when we're talking of complex retrieval rates. So we went from 240 days to 150. We continue to do different process improvement interventions, the last one being this bracelet, which is basically alluding to the patient carries that, and then the patient himself is reminded to call the clinic. So we're focusing more on patient interventions at this point, as opposed to clinician and education alone. And these are the different cycles of PDSA. We also implemented a PA clinic, et cetera, but I think the most effective ones were when we focus on the physician and the patients. So what is the initial evaluation before filtered retrieval? Well, first of all, follow up on the patients. Second of all, deciding anticoagulation. Do we have a contraindication? Is the patient going to go for surgery still? So all those things are discussed in the clinical appointment. And of course, this is a multidisciplinary based decision. We also have to speak to the other physicians to see if this is real indication for retrieval. In addition to that, dwell times and some clinical issues with perforation and complications of IVC filter also should be looked at. At our practice, we do have a lower extremity ultrasound if patient is not anticoagulated to make sure patient does not have a DVT. And most of those patients are going to have some cross-sectional imaging. I know that some practices order x-rays to see more or less the position of the filter. Regardless of what you do, I think all the things that we do in the clinic is to predict whether a filter is going to be a complicated retrieval or not. In terms of optimal timing of retrieval, some modeling studies show that it's better to retrieve it within 90 days of implantation, but of course each practice is different, each patient population is different. Now we do find in some studies that there's a benefit in retrieving up to 54 days. This is our own data, and again, it's very local, it's very different than other practices. We looked into the use of advanced retrieval techniques, and when did that happen in terms of in relationship to the dwell time. And what we found is that a significant difference of techniques when it comes to 110 days. So patients who have the filter more than 110 days, they're more likely to require an advanced technique. And I think depending on your practice, this is pretty much what you see, a prolonged dwell time. Another way of looking at the data is the position of the filter and predicting if you are going to have to use a removal, an advanced removal technique, and tilting I think is the most commonly seen. Very briefly, because we're going to address this in a couple of next talks, is the types of retrieval techniques, going from the simple first order techniques to the fourth orders, including endobronchial forceps and endovascular laser. This is more or less of our algorithm for retrieval. I think one of the things that's helpful from the clinic is to predict if there's going to be an advanced retrieval technique utilized, then we can book the patient with anesthesia and have a little bit more support, and I think that's helpful. Dissection techniques, we're going to talk about a little later on. At our practice, we use a lot of the endobronchial forceps, the rigid one, and this is an example of it. It's a little bit scary, but it does work, and we have a lot of experience with that. And so this is what we're doing more or less when we see that a filter is basically difficult to retrieve. So in summary, we are better in terms of retrieval rate, all of us, United States, but still suboptimal. The rate of placement of IVC filters still increasing, but we do have recommendations for removing as soon as the indication or the temporary indication is done. Retrieval rates or retrieval procedure can be technically challenging in about 50 to 60% of cases, particularly if you are having a prolonged dwell times and degree of tilt of the filter. Moreover, in terms of non-retrieval predictors, we find that age, malignancy, VTE, and patient factors are actually influencing the way that we look at those filters or retrieve those filters. However, more data is needed to determine the efficacy of IVC placement and also the long-term outcomes. And we do know that we have the PRESERVE trial being done, and hopefully we're going to have data on that in terms of the complications in long-term. Despite of all of that, if you place a filter, you follow up on the patients, and I do think and strongly believe that quality improvement projects and processes are beneficial for us to improve our retrieval rates locally at our institutions. Thank you.
So Dr. Salazar, you mentioned the discrepancy between the ACCP guidelines and the SIR. How do you, in the Mass General, deal with the issue of prophylactic placement of filters?
We do have a high rate of prophylactic filters, I mean, from all different departments. And I think that the issue is dealt we use the SIR guidelines, first of all. And second of all, I think it's really a multidisciplinary discussion. It's very important to have these conversations ahead of time. And again, we do implement, particularly for the prophylactic indication, a very strict follow-up so we can remove them as soon as possible. So I think it's a combination of things. There's no one size fits all.
Yeah, okay. Fair enough. Dr. Rochon, would you like to proceed?
Yes, thank you, Dr. Key. I will be presenting the IVC filters that are on the market right now, trying to be as inclusive as possible. These filters are deemed permanent, but some are, mostly all of them can be retrieved with advanced methods, as Dr. Salazar was pertaining to. So all IVC filters are FDA approved for permanent implantation. And filter design is the challenge. There's a balance of opposites, stability versus mobility, durability versus retrievability, but we need to maintain functionality in terms of the indications for these filters. As was stated, the current recommendations, implanting physicians and clinicians are responsible for ongoing care of patients with retrievable IVC filters. So you need to consider retrieval as soon as protection from PE is no longer needed. And the 2014 update favored removal of about 29 to 54 days if the PE has passed. And as was stated, a preserved trial is actually being undergone, looking at the results for safety, efficacy, and complications. In terms of difficult retrieval, things that we see are embedded hooks, increased tilt and angles of some of the filters, penetration of the IVC, filter fracture, longer dwell times, which then would need advanced techniques, as well as IVC filter and thrombus, despite patients who may be transferred to anticoagulation. Some advanced retrieval methods that were already discussed: a stiff wire technique, dual access, using a balloon to displace the filter in order to retrieve it, loop snare techniques, sandwich techniques, use of the rigid forceps, which we utilize a lot in our practice, and also laser. Types of filters, as I discussed, there are permanent. Most of the FDA-approved filters are deemed permanent. We talk about some that are optional retrievable, and there are some on the market at this time that are convertible that we do not need to retrieve. Permanent filters are typically used for patients who are immobile, who have a terminal diagnosis, older age, and poor health. Retrievable filters are removed when mechanical PE prophylaxis is no longer needed. Most of these filters have a hook that can be retrieved fairly easily within an appropriate amount of time with a loop snare or other device. This is actually a movie that shows a loop snare over the filter, all under fluoroscopy, engaging the hook, capturing, and then within the sheath it's collapsed and removed from the patient. Convertible filters are placed when you have an intermediate between retrievable and permanent. The hook is captured and removed, the filter opens, and there's endothelialization of the filter as well. The filter is actually converted to somewhat of an IVC stent. Now going through some of the commercially available filters, the ALN, it's a retrievable filter. It has the hook that we can retrieve with a loop snare and a sheath. It was FDA approved in 2008, up to 28 millimeters. Most filters are actually approved up to that amount. European approval up to 32 millimeters. It's stainless steel, and its delivery is through an 7 French sheath. These filters are typically deployed from an internal jugular approach. This is another representation of an ALN, which shows the longer legs that allow it to be centered a little bit easier within the IVC. The Option Elite filter, it's retrievable. It's FDA approved in 2009, approved up to 30 millimeters. The legs, however, open to 32 millimeters, therefore allowing for a larger cava. It's a Nitinol-based filter and a 6.5 French OD delivery length. Notice that this hook is actually welded within one construct of the filter, which allows the hook not to be straightened whenever it's actually difficult to remove. Another representation of the Option Elite, also within a patient fluoroscopically. The trapeze and Optese filters. The trapeze is a permanent device up to 30 millimeters of cava, Nitinol, 6 delivery sheath, French delivery sheath. Symmetric, same filter may be delivered from an IJ or femoral approach. The Optese is the retrievable version where it has a hook also embedded within the filter. The hook must face caudally, and the retention barbs are oriented cranially. These filters, however, are difficult to retrieve. There's a lot of turbulent flow, and we see a lot of these filters have higher rates of fracture as well as clot that may be distributed. A lot of these filters are also need dual access, sometimes a laser as well, and telescoping to actually remove them. Another representation of an Optese filter with the caudally face tines and barbs. Trapeze here as well as within the patient. The greenfield filter, one of our older filters, it is a permanent filter. However, it can be removed if the indication is no longer there, or if there are actually fractures or any other problems that may pose safety harms to the patient. It's titanium and stainless steel over the wire, still in use. The maximum base diameter is 32 millimeters, curved hooks on the struts to prevent migration. This filter typically lands pretty symmetric within the cava. It's delivered through, however, a larger sheath than most of our commercially available filters, 12 French. This is the 12 French stainless steel filter, fluoroscopic or single shot image within a patient. 24 French stainless steel, and the titanium. Comparison of all three put together. And this is the just a note of how large the tips are, because we can use several techniques, the endobronchial forceps that could grab the tip, and also some other methods such as loop snare techniques, typically with a larger sheath. The Gunther Tulip filter is a retrievable filter, FDA approved in 2000 and US approved up to 30 millimeters. It's monochrome alloy of cobalt, nitinol, and others. Delivery through a 7 French sheath. The femoral delivery system is 8.5 French. This filter has a hook. A lot of these sometimes these filters can actually tilt up to 15 degrees, which could actually make it a little bit more difficult to retrieve, with the hook actually becoming embedded in the cava. Other examples of the Gunther Tulip. This is a select filter. It has actually rounded tines, secondary tines that can actually help with centering of the filter. FDA approved in 2007. Also, similar construct of the Gunther Tulip, delivered through a 7 French sheath through the IJ and 8.5 French through the femoral approach. And this is an example fluoroscopic image along with its model as well. Other filters as well, these are G2 filters that are not on the market, but the Denali filter is on the market. It's actually retrievable, FDA approved in 2013, up to 28 millimeters, nitinol, 8.4 French delivery system. It also has a hook that can actually, it's welded and can be retrieved from a loop snare technique. This is actually some images as well for the Denali filter. The Simon nitinol was the first nitinol product actually made. It's a permanent filter. We don't see these as much anymore. However, it still can be retrieved with advanced techniques, endobronchial forceps, and larger sheaths. The bird's nest is not one that we actually tend to retrieve. In fact, some people are actually looking for it to be retrieved from an advanced technique. But it can be used as a temporary filter during lysis. It was approved in 1989 up to 40 millimeters, stainless steel, and usually a larger delivery sheath of 12 French. We don't see a lot of these in patients anymore. Safe Flow filter was FDA approved in 2009, up to 25 millimeters. A nitinol filter as well. Smaller delivery sheath compared to others of 6 French in 3 different sizes. Therefore, we must size to the cava. And it's self-centering, as you can see. It's conical shape, it's round shape that will fit the filter as well, the cava. Other examples as described here. The VenaTech filter is a permanent filter. It does have convertible options, but the VenaTech is a filter that has approximation of the cava. You don't have any problems with it tilting. It's FDA approved in 2001, legs open to 35 millimeters. It's a non-ferromagnetic alloy, 7 French delivery system, femoral IJ. Now, as I stated before, even though this filter is permanent, if there are any problems, it can be, we have seen it retrieved with advanced techniques. The VenaTech family here on the far right is the convertible filter, which we will discuss in a second. Low profile VenaTech. And the convertible filters actually uses a 6 French Amplax gooseneck snare to convert. You typically need a 9 French or greater sheath. You engage the hook, and the filter opens up and converts to relatively an IVC stent. The bioconvertible filter is a filter that we don't retrieve, but it's utilized in patients who you may have lost the follow-up. It has dissolvable sutures and converts, just as the convertible filter, to an IVC stent after approximately 60 days. And this is a representation of the BioSentry device. Thank you very much.
Thank you, Dr. Roshan. Just as an interesting discussion, there's a great deal of variety on the market here. It's almost as many vehicles as you could choose from when you go to buy a car. How do you make a decision in your practice, and maybe I'll ask the others as well, as to which filters you use?
Absolutely. First, we want to have a discussion with the consulting physicians as well as our patients as well. Things that actually make a indication for a permanent filter as opposed to an optional retrievable. Patient's life expectancy, as Dr. Salazar presented, any cancer risks, and if the patient will have any need for long-term anticoagulation and they won't be coming off. Patients who have fall risks of that sort. These are a lot of filters, and I know institutions can't carry them all. It's actually operator dependence, ease of deployment, what your lab and you are comfortable with. But I think it's very important to have both types of filters, optional retrievable ones as well as ones that are deemed that are permanent.
Dr. Salazar, how do you deal with the issue in Mass General of there's only so much shelf space and there's only so many different filters you can have?
Definitely, and I think nowadays there's even more restrictions in how many devices we can have in our hospital. So it's a multi-faceted sort of way of looking at it. I think when we decide as a team, as a group with the just the technical aspect of it, we discuss it, and if there's a new device in the market, we say, okay, let's try it, let's make sure we follow up, we get the data, and we get our own data. It's very hard with all those different sort of filters. We have to really make a decision about, do we have a patient population where this would be helpful? And then again, consulting with the multidisciplinary teams that we work with. We basically have about 4 types in our shelf, and I think that's in combination with the vascular surgeons as well, because we are embedded in this vascular center sort of multidisciplinary, so it's, but it's very hard, you're right.
And do you find that some physicians have a favorite and they just stick with it?
Yes, we definitely have. I mean, I have a favorite, I'm not going to disclose, and my colleague has a different favorite, and then my other colleague. So I think as interventionalists, we do develop our own preferences, but I think it's important to keep in mind that there's developments and refinements of
new ones all the time, yeah. And in Chicago?
Yeah, I mean, I think that's a great question that you asked, and specifically, using your car analogy, there's 12 different types of cars. You can only drive 1 or 2, I think, and so a little bit like what you're saying, Dr. Salazar, you got to pick your favorite car, I think we're all at training institutions, so I think it's important for us to have a few different cars and different filters. And really for me, I think I take a approach of, really want to do no harm to the patient. So taking an evidence-based approach, I try to find the filters, for me, again, won't disclose, but I try to find the filters that have the least likelihood of fracturing, embolizing, things that I think would be very serious complications. Right. For me, things like tilt are not as important because I think with our advanced techniques, we're able to get those out. So that's just my 2 cents on the topic.
Fair enough.
All right, well, with that said, we're going to kind of go over some case examples of standard and complex IVC filter removals. And I think it's important if we're going to talk about removal to first just briefly go over filter placement. Because I think a good filter placement will, hopefully behoove a simpler standard filter removal. So, we always first start out by getting a really nice IVC cavograms. And actually, in this, it's not depicted in this example, but I would say the majority of the time we actually place a ruler under our patients to also identify the cava. And again, this hopefully will lead to a nice placement. And so a couple things to consider. As Dr. Roshan was mentioned, most filters that are conical shaped are approved for up to about 29 millimeters in size in order to be placed safely. You always want to identify the renal vein inflow. Again, that's typically around L2, but if you're not able to reflux contrast into the renal veins, you want to look for that indentation of where that unopacified contrast is washing in. You also want to make sure that there's no extensive amount of clot that extends up to the renal veins, otherwise you're going to be placing a suprarenal filter. And then also most importantly, you probably want to place your catheter at least into the left iliac vein to rule out any variant anatomy, specifically a duplicated IVC. You can also look at prior cross-sectional imaging to verify this. Again, for me, I always take magnified spot images after placement of a filter. Again, this is very important because at the time of retrieval, you're going to want to potentially go back to these images to document integrity of the filter. Again, it'll serve as your reference when you're removing it. So With that said, let's go over the steps of a basic filter removal. Again, everybody's going to do this a little bit differently, but for me, I always, again, start with spot magnification images, again, to document the integrity of that filter. There was a recent Penn paper that actually showed this, that the fluoroscopy is going to be much more accurate at detecting these small fractures than a pre-procedure CT will be. And then we start with a repeat cavogram. Again, we want to make sure it's safe to take the filter out, that make sure that there's no clot, identify any potential filter-related complications that may prohibit standard retrieval and may want to make you think about bringing the patient back for a complex retrieval. So as far as standard retrieval goes, everybody has a different way that they're going to do this. I make my own kind of homemade set for the most part. I start with a 12 French 40 centimeter Cook flexor sheath. And then plus or minus, I'll place a 9 French Cook coaxial 55 centimeter sheath. My snare of choice is the tri-lobe Merit end snare. Again, everybody's going to do this a little bit differently. Again, for me, very important, I think, even for simple filter retrievals, to really magnify and obtain spot images while you're doing your retrieval. Again, these tines on the filters can be very delicate or very thin, and it's very important to make sure that you're not bending or doing something that obviously something that's bad. So again, those are the pictures showing the kind of a standard filter retrieval. Here's kind of a cine example of that. Here's a gooseneck snare going around a Gunther tulip here, and you kind of bring it up to that hook. And then you bring down the 9 French 55 centimeter followed by the 12 French 40 there. And you can see how actually the filter, this is a Gunther tulip, is starting to bend. And really the resistance point here is actually at the filter legs, where the legs like to get incorporated. So then you bring down the 12 French to give you a little bit more stability there. And you can see with that bending that even some of our standard filter sheets, retrieval sheets are a little bit flexible, and we may benefit from kind of newer, stiffer sheets for removal. And I believe the Argon company is actually coming out with that set. So just moving on, we're going to talk about a complex filter retrieval. This is relatively what I would consider more of a straightforward complex retrieval, but important to kind of go over some of the principles. As you can see here, this is a conical shaped filter that has that exhibits multifocal strut penetration, kind of abutting the small bowel there. And you see on the venogram here, again, similar findings of the multi-strut penetration. And we actually, anticipating that this might be a difficult retrieval, attempted a triaxial system. So as you can see, the bottommost image, the bottommost sheath there is your 9 French sheath, and then your 12 French sheath, and then we actually have a 16 French there in case we needed to escalate to some advanced techniques. And despite usage of this triaxial system for additional support, we're unable to collapse the filter due to filter strut incorporation. So basically those filter legs are starting to get scarred in. Again, this is a Gunther tulip filter, which is kind of known for potentially having this complication. And so, your options here are to pull harder, which the hook on these filters tends to be relatively weak, so that would likely straighten it out. So for my practice, I have a low threshold to convert these patients to excimer laser or laser sheath retrieval. I think this works very well for embedded filter legs. And so as you can see here, we took out the 2 inner sheaths, placed the laser sheath, and we're able to successfully laser this out using the laser sheath. Again, magnified spot images, making sure that you're slowly kind of ablating that tissue around the legs, again, using laser for photoablation. This is kind of a cartoon graphic depicting what's going on here with laser. You can see that tissue that you actually cannot really see that well on the contrast venogram, but this is actually what's happening. So the laser, although it sounds scary, is actually not really anywhere close to the IVC wall. It's actually just cutting through that tissue there. And as you can see, just a kind of a magnified cartoon image of the laser has this nice reinforced metal tip, in addition to kind of the laser electrodes there that are around there. And again, this is actually that filter depicting that scar tissue that you really can't see on the venogram during your retrieval, but that that's there when you're retrieving it.
Interesting. Well, questions I would have for you are, this retrieval set you were mentioning that Argonne's bringing out, do you know anything about that?
Yeah, so I actually had the opportunity to try the set out just a few weeks ago on what I would consider a quote-unquote standard filter retrieval. And I think some of its advantages kind of compared to my own homemade set, for example, is the outer sheath is really, really stiff. And I think that stiffness, as everybody probably on this panel knows, for even some of these standard retrievals, you need that rigidity to kind of help kind of remove the final kind of where the legs are contacting the wall.
So yeah, we have sort of the principles that I teach my guys is you need to have almost equal force down and you have up, and I'm about to show you a situation where that didn't occur. How about yourself? What do you think? What do you use as your sort of standard kit off the shelf to get out filters?
My standard shelf kit is the Cook retrieval set. But I do agree with most filters that may be in a little bit longer.
Right.
I do see sometimes the sheath actually bending or telescoping or twisting, sometimes even shearing, which is very scary. So we do need stiffer sheaths, definitely for the advanced techniques.
Right.
But I think if we have something that is standard, that has a little stiffer, then I think there can be more of one used for a lot of the retrievals.
So let's say you had a case that you had attempted, or maybe I always think of it, if someone like yourself has sent me a case and you couldn't get it out, then it's going to be difficult. Standard issue. What do you use then? What's your off-the-shelf beginning for that?
Sure, for an advanced technique,
Yeah.
I go with a 16 French sheath.
Yeah.
It's
the 45 Cook, that one?
actually 45, and sometimes there's a 55 as well for some of those taller patients. So we like to have something that's in there so we don't have to be exchanging as much as possible.
Right.
Something that sometimes the endobronchial forceps are going to go through, the laser, just prepared for, that way. Noting that the sheath is actually large, we want to make sure that it's flushed, or sometimes has a drip on it because it actually could
a lot of clot can develop.
And noting that this is an advanced retrieval, making sure that the patient is comfortable, so we don't hesitate to employ general anesthesia or anesthesia with these patients.
Yeah, I'm going to go into some of that as well. One of the things you just mentioned as well is that I always warn my guys that 16 French sheath, at the end of the case, it's very tempting to do a venogram to show that everything's fine, filters out, it all looks pretty. If you do the venogram with that 16 French sheath, you'll blow a load of clot down into the IVC. So I always put a straight flush catheter in to do my venogram at the end, because I've had that problem a couple of times as well. So Dr. Salazar, yourself, is there anything in particular that you have that we haven't mentioned that's on the shelf? What do you like to go to?
So I think, I have moved from, standard technique, that's great. We all are successful doing it, and we do have the kit. But when it comes to advanced, I think in the beginning I was a little bit more conservative and I was just trying to loop snare. And now I'm seriously just moving straight to fourth order techniques because I feel like, it's more straightforward. The whole manipulation already causes thrombosis, and you can even break the filter, right? On this pull and through and tension.
Legs turn upside down, all sorts of things. Yeah.
So just on my personal experience, I actually was very hesitant to use the force. I was, this is crazy. But it's not. Yeah. It is not, actually. You should really be cognizant of moving from first orders to fourth, depending on the patient.
I think the other thing that's happened with the forceps over the last, 4 or 5 years is that they've become smaller. There's a company, remind me the name of the company?
Lymol Medical.
Lymol Medical, yes, that makes them, and so they're not as thick as they used to be. One of the problems that we had experienced at the beginning of our techniques is when we had the bigger forceps, they would go in through the sheath, no problem, and you'd open them up, grab a hold of the top of the filter, but now this thing is so much fatter, because it's like a bird with a peanut in its mouth, you couldn't get the sheath back over the top of it again. Right. That, thankfully, that's really almost gone away with that newer set of forceps. So now, if you can get a hold of the top of it, you can usually get the sheath down. I'm going to show a case where that perhaps didn't happen as efficiently as it could have. So I'm going to really show you some kind of difficult and more complex filters and almost my worst case scenario. So, we start with a bang, and so this is a true story. I walked in on a Monday morning, no warning. The fellow, my trainee, had met, consented, and prepared the case, did a good job. The patient was on the table when I walked in. The neck only was prepped. Everybody was ready, and all the staff were organized. The micropuncture needles were open and on the kit. The wires were open, and a simple Cook retrieval kit was already ready, prepped, and organized, and everybody was wondering what I was waiting for. The history of this patient, this was a 72-year-old lady who had a history of hypertension, diabetes, endometrial carcinoma, which had been treated and cured, with a hysterectomy. She also had Wegener's granulomatosis and had been on oral steroids for about 4 years. She had had this IVC filter placed about 4 years previously, was on rivaroxaban. So why would we even bother to try and take this out? Well, at an outside hospital, she was seen for suprapubic pain 4 days prior to this admission. On that examination, she was found to have a duodenal perforation secondary to a limb of the filter going through the duodenum. She was then treated in ICU in the outside hospital for a few days for very severe bacteremia, quite sick, septic, recurrent lower extremity DVT on rivaroxaban, and was offered a laparotomy to remove the filter that was going through her duodenum. She declined the option of a laparotomy and asked to be transferred to a higher center of care, and she arrived into UCLA for this filter removal. This was, I have some still images here. You can see the limbs of the filter here, reasonably good on this picture. Now you start to see that anterior limb heading right across the duodenum. And this was the patient in a coronal reconstruction. Interestingly, at the base of her pelvis, you can see she has an abscess anterior to the bladder, an unusual location, but she had had a drop abscess from this hole that had occurred in her duodenum. Apologies for the darkness of this image. It's really there just to show you that I'm trying to get this filter into the sheath. It was complicated to get it in, but we eventually got the filter in the sheath, and I pushed the sheath down and pulled the filter up, and it was a 16 French 45 Cook sheath, one of the top-end stiff sheaths, and the sheath crumpled, and the filter jumped up about 2 or 3 centimeters, and the nurse that was standing next to me said, "What did you do?" Because the patient's blood pressure went from 140 over to 60 over. And so immediately, now remember, this woman is on the table, her groins are not prepped, she still has her underwear on, she's awake with light sedation. So we immediately pushed the panic button, got 4 units of O negative, got anesthesia to run in the room, took the lady's underwear off, prepped both groins, and got 14 millimeter Atlas balloons up into the upper aspects of the comniliac vein very quickly, because this woman was exsanguinating. And in fact, she had a hole in the right lateral wall of her inferior vena cava that I like to say you could drive a Volkswagen through. Quite impressive. And so when you reduced the balloons and did a venogram, this is what you'd see. Put the balloons back up and she'd stabilize. Anyway, the long and the short of it was we were able to get a wire from below across this torn cava up and snare it out the neck, and then bring down stent grafts. We initially used 2 limb extenders, and then finally a 26 millimeter diameter, 10 centimeter thoracic aortic stent graft in her inferior vena cava, and managed to stabilize her and save her life. And you can see here that the stent graft's in place, the cava is wide open, and the filter is still there because we just pushed it to one side. Interestingly, there isn't that much blood in her abdomen. It was more shock than it was blood loss, really. Anyway, she stabilized. But what did I learn? Most of what I learned I already knew, but I allowed outside factors to influence my decisions, basically like a poor airline pilot. I did get the plane on the ground safely, but what would I do if I was doing this case again tomorrow? When I walked in the room, I would have reviewed the information in much more detail, canceled the case, deal with everybody's anger and upsetness, talk to the family, and reschedule that patient with general anesthesia, blood, multiple devices, and obviously prep multiple sites. Would the cava still have ruptured? Probably, but I would have been much better prepared for it, and this situation would have been much more manageable. I could easily have lost that patient. Thankfully, it did not. So what are really bad filters? Well, the ones that we consider to be scary or most concerning are the non-conical filters. As the gentlemen before me were talking about, the trapeze and the obtuse filter. Those are non-retrievable, and one of them is retrievable, but if they've been in for a fairly long time, the cava tends to scar around those filters, and they can be very difficult to get out, so we'll always worry about those ones. Filters that have a inferior vena cava that's thrombosed around it, even if it's a conical filter. If there's IV3 thrombosis, that's a dangerous, difficult filter. And then lastly, as was mentioned by Dr. Salazar, just patients who have a long dwell time. If I see a case that's over a couple of years in place, that's a very difficult situation. So in those cases, as I have learned, you need to plan for the worst. You need to realize that there's a failure rate, anticipate the possibility that you may have to leave the filter behind and stent the inferior vena cava open, and have a deep understanding of the techniques you might need to employ if the cava does tear. This is one of hundreds of cases that I've done and the only one in which a cava tore, but I still think about that case. Now, most of these really tough cases are still removed from the neck. Use a bigger sheath, as we've discussed a few seconds ago, forceps, etc. What I would recommend is placing a wire from below into the bottom of the filter just as you're about to pull it out. And it's a standard technique I do now. I get 6 French access in the right groin, do a venogram, put a guide wire up into the base of the conical filter, and then I close it from above. And so now my Amplat super stiff wire comes out the neck with the wire. Those are in the really hard cases. And so if anything was to happen to the inferior vena cava, I have through and through access. And it's just a tip that most people don't talk about, and it's for those really hard ones. Perhaps your colleague has struggled for 4 hours and has sent you the case. And here's an example, as was mentioned by Dr. Ahmed before, of the bottom of a Cook Gunther tulip filter that they can get incorporated into the wall and require advanced techniques. And as he mentioned, the endovenous laser technique can be useful for this. The image on the extreme right there shows you just where the small legs are incorporated into the wall of the cava. And I found those to be really quite tricky. And certainly the doctors in Stanford wrote some very interesting papers about using laser to help with this particular problem. So can you try and pull too hard? Well, yes, you can. So this was another case of mine. This was a 56-year-old triathlete who developed dyspnea in January of 2012. He had an injured knee, wore a brace when he was running, got a DVT, and had a pulmonary embolism. He had his filter placed and a thrombectomy performed for his DVT. Everything was done fine there, but he developed back pain. He was now on anticoagulation, and he wanted this filter out. If you look closely, you'll see the posterior limb of the filter touches the anterior aspect of his vertebral body, and he could specifically say that prior to this filter he had no back pain. With the filter he had severe back pain, and he could almost point to where this thing was. So there was a reasonably good indication to take this filter out. It had been in about 10 to 12 months, I think, by the time we got to him. So difficult filter, it was tilted. We had to go loop snare through and through access. That didn't work. So eventually we came down with a pair of forceps, got a hold of the top of the filter, slid the sheath down and pulled hard. Filter came out without any problems. The patient went home. He comes back 2 weeks later complaining of abdominal pain. And as you can see on this 2-week post-CT, his inferior vena cava is very abnormal. He's got a hematoma around the suprarenal aspect of his inferior vena cava, and in fact the renal veins look like they're higher than they should be. So essentially he intussuscepted his inferior vena cava up into itself, and you can see on the MR there's a complete, almost membranous occlusion of the cava now, where this inner lower cava came up into the upper cava. Quite dramatic, and he was pretty symptomatic. So we did a venogram, and again you can see very abnormal, very poor flow through this intussuscepted cava with collateralization around it, really very bad looking. We put a temporary filter in because we were worried about thrombus within this hematoma. There wasn't really any. We angioplastied him. He got a little better, and his venogram at the end shows some flow through. Still a collateral, but some flow through. He goes home, comes back 2 weeks later, still in abdominal pain. Another venogram 2 weeks later, again you can see he's collateralizing through his kidney. His renal vein is abnormal, elevated. He still hasn't been sorted. So what I did in this situation was I put a balloon, almost as like you were reducing an intussusception in a child's colon, put the balloon above the intussusception and pulled down, and sort of de-intussuscepted the inferior vena cava back into position with a 24mm atlas. And thankfully, in this situation, he got better, and he recovered and is doing very well long term after this. But it was a very distressing situation, so you can pull too hard. My last 2 pieces of information basically are just techniques that we developed when I was up in Stanford, and then some more work at UCLA. And one of the tricks we came across was this idea of putting a wire through and through the filter legs, and then putting a snare around that wire and advancing the snare using the first wire to center the snare at the area of the hook, and almost put a little tension on that first wire and then throw the snare down over the filter. And that actually worked really well. We wrote this up and thought we'd solved all the problems for everybody in the future, but it wasn't perfect. We had a couple of failures. The other technique that we developed was this idea of what we call the Hangman technique. So the images you're looking at on the left-hand side, this is a through and through wire through the body of the filter. What can happen when you pull on that wire to bring the filter up or to straighten it is, in fact, it tilts more. The fulcrum is too low and the filter just shifts over and actually embeds itself even more and can get you into all sorts of problems, and perhaps is best dealt with by a forceps. But the other technique we found is if you can get a wire around the neck of the filter, so above the body, below the hook, so-called in the neck, and get a wire around that area, when you pull on the wire, it will in fact take the hook away from the wall and straighten it up. And here's an example of that to finish. This is a Cook Select filter which had a tendency to tilt, because it has a tendency to perforate. The more modern one doesn't do this nearly as much, but you can see that this filter has penetrated on the right lateral aspect and then has tilted with the hook embedded in the left side of the wall. We could not get at this with standard techniques. So what we did was took a sauce or a reverse seeking catheter and got it around the neck of that filter below the hook, above the body, and got a wire then through and through, snared the wire back up the 16 French sheath, and we're then able to center that hook, get it into the filter. At this stage we had to get another snare onto it, but now the hook is in the sheath and we can get the filter out, and it worked. So those are kind of the worst case scenario cases. I didn't think it would be any value to show you cases that we did that went perfectly. Obviously a couple of those cases did not go at all perfectly, and I guess there's going to be a couple of questions, so I'll let you guys ask questions of that perhaps.
Yeah, Dr. Key. Great cases, by the way. I mean, tremendous learning points, I think, for all of us that do these cases. You know, those are the things that we fear probably when we do these. So the one thing that's going through my mind just watching those is, you know, what are the biggest takeaways? Like if somebody is watching this lecture and wanting to get involved in, you know, doing more complex filter retrievals, you know, what would you tell them?
Well, I think the 6 Ps, you know, poor planning precedes pathetic performance. You know, if you don't plan properly for these cases, you're going to get burnt. And that's the first case was really to illustrate that probably the biggest single scare I've had in my 30-something years of doing this was what happened when that filter came up 2 centimeters and the cava tore. And I could you feel the hair in the back of your neck. And I thought that the situation was irretrievable. But we managed to get out of that with a live, healthy patient who's still alive today. Why did that happen? Well, it happened because we didn't plan properly. And so you've got to take into consideration what are you dealing with, what could you need. If you feel uncomfortable at the beginning of that case, and I did feel uncomfortable, I should have just said, I ain't proceeding, I want general anesthesia and blood, and get some more devices over to help me in case something like this occurred. Would the complications still have happened? Yes, but I would have been in a much better situation. So I think the first rule for cava filter removal is have a plan. And so I would say a simple standard filter removal technique, use your standard devices. If it doesn't work in 15, 30 minutes, move on to the next step. Don't stay with that for 4 hours like we used to do in the old days, because now your radiation dose is really high and your exhaustion level is too high also. So have a standard set of techniques. If you don't feel comfortable moving from standard technique to advanced technique in that situation, stop the case, send the patient home. This is not a life-threatening illness, and bring them back with anesthesia and blood products and the appropriate equipment. And I think that's the take-home message here.
No, Dr. Salazar, you talked about the IVC filter clinic that you have. A lot of these patients are actually coming in from referrals from outside institutions. We try to follow them in a virtual way or a clinic way. As you stated, Dr. Key, preparation and planning is really important. A lot of these patients we see for advanced filter retrievals in our clinic to discuss. I mean, that's a method where we can sit down, discuss with the patients what we're going to do, all the risk factors, the benefits and risks of removing this, and allows us to sit back and also plan appropriately for this.
Yeah, no, I agree. I think unfortunately in our profession, when patients are transferred into hospital, everyone expects that you simply are going to do them the next morning.
Yeah, right.
You know, no surgeon operates that way.
Right.
You know, they have a day that they're going to operate on, they see the patient might wait for a day or two before the surgeon's ready to treat them, but we, for some reason, don't act the same way. And I think, you know, there are these situations where you just have to say, wait a second, okay, yes, the patient's on the table ready to go, but that doesn't mean that it should be done. Or talk to the patient in clinic, like you've said, and said, I'm going to set you up for next Wednesday, and that gives you a few days to make sure your laser isn't being used by the cardiologists because it's pacemaker wire, you know, that type of thing. I think those are the lessons that I've really learned over the years. And if I'm doing another case, that's what I do first of all. I look at the case, get as much information as I can, pick a day to do the case, and then proceed.
I think the cases were very interesting. I know this is like really high-end.
Worst case scenario.
You know, but I think we do see sometimes when we remove a filter, small perforations, and then the question is what to do. And of course, the patients are not crashing. Even with standard techniques, you may have that. So what is your approach? I mean, we usually obviously observe the patient and maybe angioplasty the area and wait a little bit. And then the question is, when do we start anticoagulation? So all those things. So what is everybody's approach in terms of having a complication not quite like yours?
Not as bad as that. Yeah, Dr. Roshan, what do you think?
Sure. So have a balloon available to go ahead and do a little prolonged inflation at that point. A lot of times, I mean, whenever we're retrieving these filters, an indication, they're anticoagulated, so we don't stop it. So prolonged inflation, wait, be patient, assess the vitals, see if your anesthesia team is available, give everyone the heads up that we get a lot, and then see and just monitor that patient accordingly. If we have that microperforation, then you want to monitor the patient a little bit longer in your post-procedural area, plus or minus overnight admit for observation. Those are things that I would actually be considering.
Perfect.
Yeah, I mean, I would second that, Dr. Roshan. I think one major point is, like you started by saying, is if you're going to do these cases, I think you have to either have stent grafts or large balloons in the room. You know, and that's there's no deal on that. You know, you have to be prepared for those
almost
situations.
Almost malpractice not to have that stuff ready.
I agree. But I think we've learned a lot about what would be essentially asymptomatic caval pseudoaneurysms. I think because the IVC is a low pressure system, it's in a confined space. We're not making retroperitoneal incisions, and a lot of times these patients are anticoagulated. I actually, for me, I'm not terribly worried about them. I have a very low threshold to angioplasty and prolonged angioplasty because there's really no downside to that, I think. And then I probably keep the majority of them overnight, again, just to monitor to make sure nothing happens. But my experience has been that as long as they're asymptomatic, there's really nothing to do. I would highly, I try not to stent patients because you just remove metal. The last thing I want to do is place more metal in them. So that's my approach. And really the one time that I've seen a quote-unquote pseudoaneurysm be problematic, that patient was in 10 out of 10 pain immediately post-procedure. So I knew at that point there was something more there, that we had to bring back and do something about. But the majority of them, I think, do largely pretty well.
I think another area that's worth discussing, certainly in our practice, we're moving more and more towards outpatient-based therapies. I mean, we're opening clinics all over the place and then putting interventional radiology in those clinics. I recommend to my young guys who are in those clinics that if you can't get an IVC filter out with standard techniques, do not apply advanced techniques in that environment. It's just not appropriate. I mean, patients can't stay overnight. What are you going to do with them? So, I think for people who are in the outpatient practice, and I know there's a lot of IR now being done in outpatient practices, I think if you have to go beyond standard techniques, maybe a really simple pair of forceps, but nothing more complicated than that, I would bring the patient into hospital for further techniques.
Well, would you still recommend IVC filter retrieval for outpatient? The low risk cases?
I think I would. I think, certainly if I was ill and I had to have an IVC filter placed, I would make darn sure that filter was taken out before 6 months, because I've seen so many caval thromboses and back pain and then duodenal perforations. I mean, it's not as rare as people think. If we all got together as a society and said, how many of you have seen a duodenal perforation? Almost everybody's seen at least one.
Right.
And that woman was extremely unwell in ICU with fevers because of it. So, I think that piece of metal in your body long term, I want to get it out. Yeah. Definitely. So. Okay, so we're going to finish up here. I'd like to thank Dr. Salazar, Dr. Roshan, and Dr. Ahmed, myself, Dr. Keefe, for being here today to talk to you all, and thank you all for listening. I'd especially like to thank Argonne Medical Devices for the educational grant support that made this whole discussion possible. Thank you all very much.